Good afternoon, everybody. As you're enjoying your lunch, I want to welcome you all to this symposium. My name is Ron Wald. I'm a nephrologist at St. Michael's Hospital and the University of Toronto in Canada, and I'm really privileged to moderate this session, speak at it, and also welcome two wonderful speakers, who you'll be hearing from very soon. I want to thank Baxter for sponsoring this session, and if I could just say a few words about Baxter's role in critical care nephrology. We know about the products that Baxter makes for sure, but I'm really grateful for their investment in this field, not just as an industry and a business partner, but really as a company that truly stands by the patients who suffer from critical illness. I know that my colleagues at Baxter Canada, all the way up to the senior echelons at Baxter, have always been very supportive of research in this field with unrestricted grants and education. So again, I just want to express my deepest thanks to all my Baxter representatives and friends in the room. So thank you very much. I'd like to introduce my first speaker. Dr. Tiago Reis is a nephrologist at the Syrian-Lebanese Hospital in Sao Paulo, Brazil. His big interest is in critical care nephrology, and he'll be speaking to us about nomenclature in acute kidney injury and extracorporeal therapies. What's in a name, and aren't they all the same? Tiago, please.
Good afternoon. So this is a product of a meeting held in Rome 2022, where Professor Ronco was leading this event. So we published 3 papers in blood purification after that, and I will cover mainly what is in those papers. So these are my disclosures. This is one of the papers. This is the second one. And after that, we also published a letter in the Lancet because of the issue concerning kidney and renal terminology. So Rinaldo Bellomo wrote that this purge would of the introduction of continuous kidney replacement therapy, which sounds weird. This course is CRT, not CQRT. And some situations, like when you submit papers, some editors are asking you to replace hepatorenal syndrome for hepatokidney syndrome. And they say it's because patients know what hepato means, but they are confused with renal. We have a point on that, right? One interesting thing is that in this meeting, we decided to use the term extracorporeal blood purification instead of extracorporeal organ support. However, I'm going to the next session, and the name of the next session is ECOS. So you see, it's hard, and Professor Mehta was there leading also this meeting. So even in the community, we are so used using those terms that we haven't already adopted all of them. So as I mentioned, we prefer the term renal replacement therapy instead of KRT, CRT instead of acute dialysis or CKRT. Concerning PIRT, so prolonged intermittent renal replacement therapy, we are all familiar with the term SLAD, but the preferred term would be PIRT. We should avoid also acute dialysis because acute refers to disease, not to therapy. And concerning SCUF, where the encouraged term is isolated ultrafiltration or isolated UF. And finally, today we had a lecture about hemoperfusion, but the preferred term would be hemoadsorption, abbreviated as HR. We also defined basic terms like ultrafiltration and convection. Before that, I thought they were synonyms, but actually, when we talk about ultrafiltration, we are referring to the solvent crossing a semi-permeable membrane, whereas when we talk about convection, we are talking about the solids that are dragged in this movement of the solvent. So this is like difference. Another debate concerns ultrafiltration and fluid balance. So the way I explain to my residents is that when you talk about fluid balance, you are talking about the patient. And when you talk about ultrafiltration, you are talking about the machine. In fluid balance, we have what gets in the patient, such as diet, IV fluids, and what gets out It's the net ultrafiltration, urine output, fecal losses, perspiration, and insensible losses. And here we have a clear example on CRT of what actually net ultrafiltration means. So imagine that you're using like Regisit regional citrate anticoagulation, and then you have a pre-filter replacement of 1,000 mLs per hour. Okay, you're doing also post-filter convective clearance, 1,000 mLs per hour, and you want the patient to lose 200 mLs per hour. So your total convection here, your total ultrafiltration would be 2,200 mLs per hour. However, your net ultrafiltration would be the total ultrafiltration minus the replacement fluid pre and post. So this is the definition. This is like physics. This is how you define also filtration fraction. So I don't think that we should be debating on that, but we are, unfortunately. A new nomenclature too concerns expanded hemodialysis. I will go through that in a minute. And the abbreviation is HDX. And we should avoid the terminology middle cutoff hemodialysis, MCOHD, or protein leaking hemodialysis, or super high flux hemodialysis, just HDX. And also concerning disposables. So we prefer the terminology, we as a community, when I say that, the terminology filter instead of membrane, dialyzer, or hemodialyzer. I confess, all the time I use the term dialyzer, but I should try to improve that and turn to filter. The same for cartridge. So in the literature, sometimes you see they are mentioned like sorbent, column, resin, and this is so confusing for us, and imagine for the residents. They think they are different things. So it's preferred to use cartridges and filters instead of the other possibilities. And also for the fluids. So we have the term dialysate, which is preferred over solution for dialysis or fresh dialysate, and effluent instead of spent dialysate. When we do only ultrafiltration, there is no spent dialysate, but always we have effluent, for example. And here is a representation of all the therapies that we can apply. This will be published in a book this year. And we also defined the nomenclature for the membranes. And like, let's say 10 years ago, we were kind of restricted to low flux and high flux membrane. And we classified that only based on the ultrafiltration coefficient. However, we have other membrane properties that are important. And now we use these other properties such as the retention onset or cutoff to refer to those new membranes such as the median cutoff and the high cutoff membrane. So this represents the sieving curve. Imagine that in the x-axis we have molecular weight, and in the y-axis we have the percentage of removal of the molecules. So the retention onset is the point where above that point we have a removal of 90% or less of a given molecule. And the cutoff is the point where after that we remove less than 10% of that solute. So we came with this theoretical concept. Imagine that we have this first membrane. This, I cannot show, let's see if I can put it over there. Laser pointer. Yeah, it's there, all right, lovely. So we have this membrane here. We can observe that the retention onset is really for low molecules, which is not good. And then because of a lack of uniformity in the pores, this membrane has a high cutoff. So then you lose proteins such as albumin that you don't want to lose. Then we have this other kind of membrane which has a fair retention onset, and here would be the cutoff. But this would be an ideal membrane in which you have a high retention onset and a cutoff that does not allow you to lose important proteins such as albumin. Concerning the pore size, when you compare here a high flux membrane, this would be the mean pore size, the distribution of the pores, because they are not all of the same diameter, and this would be a high cutoff membrane. We can observe from scan electron microscopy that would be a high cutoff membrane with wider pores versus here a high flux membrane. And then we have those two kind of new membranes. We have the high cutoff and the medium cutoff. The main difference between them is because the medium cutoff membrane has more uniformity in pore size, so that you don't have a lot of pores with a wide diameter that would allow you to have unwanted losses of albumin. And this is the representation of the sieving curves for all those membranes. So here is the low flux membrane, here would be the high flux membrane, here would be medium cutoff membrane, and here would be the high cutoff membrane. So let's say for beta-2 microglobulin, if you use a high flux membrane, then you have a sieving of 50%, which means 0.5. So you're removing 50% of that beta-2 microglobulin. If you go like to a MCO membrane, medium cutoff membrane, we can see that for this molecular weight, we are almost removing 90% of beta-2 microglobulin. So, as I've mentioned, these two variables, the retention onset and the cutoff, are now used to classify the membranes. And we have the term established as HDX. And it's interesting to explore how those membranes work. So we have here in the audience Professor Claudio Bronco with more hair in that occasion. It was in the 80s. And we have this property of filters that when blood goes inside the filter, you have more pressure in the blood compartment and you have an efflux of fluid from the blood compartment towards the dialysate compartment. In a certain point in the hollow fiber, the pressure there is lower than the pressure in the dialysates, so that you have the opposite phenomenon. You have an influx of fluid from the dialysate space towards the blood compartment. And this is termed backfiltration. Interestingly, back then, this was a negative characteristics of the membranes because the quality of the water was not ideal. So you will put in inside the blood things that might contaminate the patient. Now that we have purified ultra pure water, this is not a problem anymore. And this phenomenon of backfiltration was demonstrated in Vicenza. They used in this case a tracer in scintigraphy. So they simulated an extracorporeal therapy, and this tracer could not pass through the membrane. And what we see is that when the fluid gets in the filter, you have a concentration of that tracer because you're losing fluid, but then because of backfiltration, you have a reconstitution of that fluid and then a dilution in the tracer, so proving that the phenomenon of backfiltration really exists. Comparing a high flux membrane with an expanded hemodialysis membrane with an MCO membrane, we have a more pronounced phenomenon of backfiltration. This was indeed measured in Vicenza always. So for a median cutoff membrane with a surface area of 1.7 square meters and a blood flow of 300 mL per minute, we have 29 mL per minute of backfiltration. If we increase the area of the membrane, then with the same blood flow, we have 31 mL per minute. Using higher blood flows, 400 mL per minute, with the very same membrane, you see that we have an increment from 29 to 41 mL per minute of backfiltration. So backfiltration means convection. So we are doing dialysis, but we do have convection as if we were performing hemodiafiltration. And finally, with the 2.0 square meter membrane with a blood flow of 400, we have 52 mL per minute. Just putting into context, when we perform ideally HDF, to reach 23 liters in one session, we need to have a convective volume of around 95 mL per minute. And I want to stress the importance of blood flow. Some studies with HCO membrane, high cutoff membrane, and medium cutoff membrane, they utilize the blood flow in CRT of 100 mL per minute, 120 mL per minute. But with lower blood flows, you cannot take advantage of those properties. So if you want to take advantage of a high cutoff membrane, a medium cutoff membrane, then you need to use higher blood flows. Here is an example. for middle molecules, if you are applying a blood flow of 300 miles per minute during 4 hours, this is the clearance of those molecules. So, for example, let's take, for instance, beta 2. It's 64 mLs per minute of clearance. If with the same membrane, an MCO membrane, you increase blood flow to 400 miles per minute, see that you have a jump from 64 to 84 mLs per minute. So as I've mentioned before, if you're doing CRT with citrate, you will, and necessarily low blood flows, then you'll not take advantage of the membranes. Myoglobin, as I've demonstrated also here, is a middle molecule. With these membranes, we can reach a clearance of 59 mLs per minute using a high blood flow. And there are studies comparing the removal of myoglobin in patients with rhabdomyolysis. So the removal ideally should be done with a medium cutoff membrane, because you remove a lot of myoglobin, you don't lose a lot of albumin that occurs when you apply a high cutoff membrane. And interestingly, the removal of myoglobin is comparable that when you use a cartridge for that purpose. There are also functionalized membranes. So one example is the AN69ST. So in this figure here is a representation of a hollow fiber, and we have two layers here. The inner layer is of PEI, and it's positively charged, so has properties to absorb endotoxins, whereas the external layer is from acrylonitrile and is negatively charged and has properties to absorb cytokines. So here would be the representation of an evolution of this previous membrane, which has add on it in the inner part heparin grafted, so that you are less likely to have clotting phenomena. Now switching gears to biomarkers, which is really interesting. So there is the definition of the FDA about a biomarker. I read it here. A defined characteristic that is measured as an indicator of normal biological processes, pathogenic processes, or biological responses to an intervention. We have 4 types of biomarker. So molecular ones that we speak more about them, but also histologic, radiographic or imaging, for example, renal resistive index, and physiologic, such as urine output and also blood pressure. So all those are biomarkers. And not a biomarker is how a patient feels, functions, or survives. And here I've illustrated some examples of biomarkers, and I want everyone to not think of biomarkers only when we are talking about molecular biomarkers. And before studying that, I had that concept that biomarkers were only things that we are measuring in the lab, which is not true. So I've listed some examples of molecular biomarkers that we are more familiarized with. For example, serum creatinine, urine albumin creatinine ratio, dipsticks urinalysis, and serum cystatin C. Okay, those are traditional molecular biomarkers. We have the new molecular biomarkers such as IGF-PP7, NGAL, KIM1, also FINA. I was in the liver session before. FINA is a molecular biomarker. We have kidney biopsy, so this is a histologic biomarker. And we have imaging biomarkers such as ultrasound in the B mode, and other imaging tests such as renal scintigraphy, renal resistive index, Doppler from the renal vein, and also fluorescent agents tracers for GFR determination. Also, urine output is a physiological biomarker, and that goes to for like creatinine clearance, the renal functional reserve, which was really explored a lot in Italy and in Vicenza. And interestingly, the furosemide stress test, this is a biomarker and it's a physiological biomarker. We can also divide biomarkers in their category, and the same biomarker can be in different categories. So for example, a diagnostic biomarker detects or confirms the presence of a disease or condition, and albumin is a diagnostic for example, chronic kidney disease. We have monitoring biomarkers. They assesses the status of a disease and is measured repeatedly. And again, albumin can also be considered in monitoring biomarker. When you start SGLT2, you're following patients with that biomarker, but also creatinine, NT-proBNP, and blood pressure. A prognostic biomarker identifies disease recurrence or progression in patients with that disease. So I will explore in the next slides CCL14. So it tells you about the risk of the patient having persistent AKI requiring dialysis. But also, for example, when you have patients with autosomic dominant polycystic kidney disease, when we do routinely the CT scans to measure total kidney volume, this is also a prognostic biomarker. The higher is your total kidney volume, the worse is your prognosis. And finally, safety biomarkers. So also albuminuria might be a safety biomarker when you're treating patients with cancer with antivascular endothelial growth factor antibodies. If your patient develops albuminuria, this is a sign of toxicity, of endothelial toxicity of that agent. And for example, when you treat patients with AKPD and use tuvaptan, you assess the markers for liver toxicity. And I'm closing to the end. So, for example, in this trial, they use CCL14 as a prognostic molecular biomarker in around 300 patients they had already AKI established stage 2 and 3. In this cohort, 33% of the patients developed persistent AKI and 67% not persistent AKI. If you apply a cutoff for CCL14 of 1.3 nanograms per ml, you have the sensitivity of 91%, but a low specificity for diagnosing persistent AKI. If you increase that threshold to 13, 10 times more, then you reduce your sensitivity, but you increase a lot of your specificity, as with any other molecular biomarker. And finally, this study is really interesting because it combined two biomarkers. One molecular biomarker, which was CCL14, but then a physiological biomarker, which is the furosemide stress test. And then you might have 4 possible scenarios. So 200 patients, it was an observational trial, and surgical patients with already developed AKI stage 2, they were submitted to the furosemide stress test. So this is one of the conditions. So you have the patient that has a positive response to the furosemide stress test and has a low CCL14. So in those patients, 13% developed AKI stage 3D requiring, of course, dialysis. In this other group of patients, they responded to furosemide and they had a positive molecular biomarker, but in this cohort, in this group, only 8% of patients required dialysis. Then we have this down here in the left, patients that did not respond to furosemide stress test, but they had the negative biomarker, molecular biomarker. So also in this group, the need for dialysis was low. But the most interesting is this group here, patients that both, they did not respond to the furosemide stress test and they had high CCL14. So in this group here, we have a need for dialysis in 70% of the patients. So if you combine and you get to this situation, you can decide things like, oh, I'll place a perm cat in this patient because I can foresee that he has a high probability of requiring dialysis for a longer time. So yes, this is really interesting to explore. Thank you for your attention.
Yeah. Any questions for Dr. Rees? Thank you very much for a great talk. Okay. All right. So we will go on to the next speaker. It's a privilege to call Dr. Manish Kaushik to the podium. Dr. Kaushik is a nephrologist at Singapore General Hospital, where he is the head of the hospital's critical care nephrology program. He is also the chair of the nephrology chapter of the Singapore Association of Physicians. So thank you very much for joining us today.
Thank you, Ron, for the very kind introduction. Set my slides on here. And I would like to thank Baxter for this opportunity to share in this symposium. And what makes this symposium even more special for me is when you have your fellowship teacher and supervisor and mentor, Professor Ronco, in the audience listening to me. So that's a little bit intimidating, but I hope I will do him proud. Okay, so what has been assigned to me is to talk on membranes and what is the difference and what difference do they make. And I'm going to take it a little bit different. Instead of speaking about membranes in the context of hemodialysis, I'm going to speak on the influence of membranes in acute kidney injury and in the performance of CRRT. These are my disclosures. So did that go? Yeah. So basically, we will just go through a few of the AKI phenotypes. Then we are going to talk on the CRRT hemofilter membranes. And I'll discuss a little bit about the sepsis cascade and the use of high cutoff membranes and cytokine absorbing hemofilters in the context of AKI. So we are all aware that AKI through the various organ crosstalks can lead to multi-organ consequences. For example, encephalopathy, for example, pulmonary edema or systemic hyperinflammation. But though the consequences of this AKI may be similar, the way the patient reaches that AKI may be through different pathways. So for example, I'm just highlighting a few scenarios. You could have a 36-year-old patient who presents to you with AKI secondary to a tumor lysis syndrome in the background of a cancer. And here we are essentially dealing with probably uric acid deposition for hypovolemia, and of course the life-threatening consequences of AKI in terms of hyperkalemia, hyperphosphatemia, or hypocalcemia. Or we could have a patient with AKI secondary to rhabdomyolysis, where the AKI may be mediated by the direct myoglobin injury or bile pigment or pigment cast. Or you could have a post-cardiac surgery patient who could have multiple hemodynamic perturbations during surgery, many mechanical factors, and inflammation as their pathogenic mechanisms, and especially when they are on the bypass machine. On the other hand, we could have another surgical patient, for example, a post-abdominal surgery patient who may develop AKI because of myriad of pre, intra, and post-operative factors like hypovolemia, hypotension, increased intra-abdominal pressure, etc. There could be also patients who develop AKI in the background of a sepsis, and this we know is mediated through the inflammatory cascade of PAMs and DAMs and the downstream effects of these mediators and their effect on inflammation, on the inflammatory cascade. Or we could have patients with acute liver injury who develop AKI because of hepatorenal syndrome, because of ATN, or just pre-renal hypovolemia. Now, in our current practice, irrespective of what is the pathogenic mechanism of AKI, our current approach with renal replacement therapy centers around mitigating the life-threatening consequences of AKI and trying to establish an adequate solute, acid-base, electrolyte, fluid balance control in these patients. And we have attempted many interventions and many trials have undergone. We have undergone in the performance of RRT to see how we can best influence the outcomes on these patients. For example, we have had multiple trials that looked at the timing of dialysis initiation and whether that could influence the outcomes. We have had trials that have looked into modality of dialysis and then their impact on the outcome of these patients. We have looked at dosing CRRT in different doses, high doses and standard doses, and looked at their influence on the outcomes. And of course, we have had various methodologies of anticoagulation. But unfortunately, none of these trials has identified any one methodology or mechanism that may help to influence the outcome in these patients. Now, irrespective of the modality of dialysis or the way we perform dialysis, there is some basic commonality. And the mechanisms of solute removal during dialysis are essentially three: diffusion, convection, like has been discussed, and all membranes have certain property of adsorption to varying degrees. And all this action that is happening in dialysis is actually happening inside the hemofilter, and the interface or where the blood contacts the dialyzer is at the membrane. Right? So I would tend to think that it would seem logical to know a little bit about these membranes, because this is where all the interaction happens. Now, so the main characteristics of a CRT filter that affect the clearance of middle molecules and the larger molecules are, of course, the surface area of the CRT hemofilter and the membrane structure and composition, especially in terms of its porosity, the size of the pores, the density of the pores, and the number of the pores, and the specific properties of a membrane, specifically with regards to adsorption. Now, in CKRT, unlike in intermittent dialysis, as we have learned in the workshops yesterday, a clearance is dependent on the effluent flow or the dialysate or the ultrafiltrate flow that we are achieving. And therefore, the influence of a filter surface area on the clearance may not be very much. And in that context, I will probably not discuss much about the surface area of filters, but we will focus our discussion on membrane structure and composition. So as we are well aware, membrane technology has moved along, and there have been a lot of innovations along the years. From the very early years of dialysis, where we were using cellulose or modified cellulose membranes, we have now almost consistently been using synthetic membranes. And synthetic membranes are nothing but alloys or copolymers of greater than one non-cellulosic alloy. And depending on the copolymers that we use and their manufacturing process, there is an array of synthetic membranes that is commercially available now, right? And I have highlighted some of these membranes in the cartoon. And how these are manufactured will influence their solute clearing properties of these membranes. And as we can see here, the shape of the membrane and the structure of the membrane may also influence their capacity to adsorb. And some certain membranes have a greater adsorptive capacity, like the polyacrylonitrile or the polymethyl methacrylate membranes. Now, here's just a diagrammatic display of how dialysis membranes are made. They are basically manufactured by running a core fluid and a polymer solution through a spinneret, and then precipitating, washing, and then after treating these membranes to help control its integrity and dimensions. And now, depending on the polymer solution and the core solution that we use and the modifications we employ during the manufacturing process, we can influence the pore size, the pore density, and the pore size distribution in a membrane. And this is an important characteristic of the membrane that influence the permeability and the ultrafiltration or the hydraulic capacity of the membrane. And as Thiago had just had just discussed in the previous lectures, the molecular weight retention onset, which is a newer characteristic of the membrane being described, is the molecular weight at which the saving coefficient of a membrane for a particular weight becomes 0.9. And as we can see with the newer membranes and advanced technologies, the slope between a molecular weight retention onset and the molecular weight cutoff becomes steeper and steeper, allowing us safer removal of larger and larger size molecules without the significant adverse effects of protein loss or albumin loss from these membranes. And the general cutoff of the membranes has moved from the conventional 20 to 30 kilodaltons to 45 to 60 kilodaltons for medium cutoff or high cutoff membranes. And there has been a revision of how we classify membranes. They are no longer classified just as a high flux or a low flux membrane. And this is one of the proposed classification. As you can see on the top right corner is where the high cutoff membranes is. And if you look at the molecular weight retention onset on the x-axis and the molecular weight cutoff on the y-axis, they are both almost matching each other in terms of their molecular weights. Now, on the other hand, the synthetic membranes, they are usually derived from petroleum, and so they are inherently very hydrophobic. And therefore, they are quite good for convection, but the presence of hydrophobicity does not create a continuum of the fluid phase in the membrane. And therefore, to make these membranes more wettable and to allow them to be used for dialysis, we have to add in certain hydrophilic segments in it or hydrophilic substances in it to allow these membranes to be used both for convection and dialysis. And therefore, we are now currently looking at dialysis membranes from a multi-dimensional point of view and not just in terms of their flux. Now, a couple of characteristics of the membrane that I would like to highlight here, which have a relevance on how we perform and how they are used in CRT, is this concept of zeta potential, which is nothing but an electrokinetic potential in the colloidal dispersions. And it is the potential at the blood membrane interface due to the presence of electronegative charges located in the skin layer of the membrane. The skin layer of the membrane is where the membrane interfaces with the blood, and it is the most important layer. And the magnitude of this zeta potential, it indicates the degree of electrostatic repulsion between the membrane and similarly charged solutes or particles in the blood, or if there are opposite charges, how well these solutes will kind of bind and get absorbed on the membrane. And it will influence how various solutes that are present in the blood get cleared when this blood passes through these membranes. Now, as I've mentioned earlier, the most important component of the membrane is the internal skin layer, and because that is the surface that establishes the interface with the blood. And in today's day and age, more than half the membranes that are commercially available have some form of proprietary membrane surface modification that has been performed. And there are various ways in which you can modify this, the skin layer of these membranes, like in terms of chemical reaction by addition of certain substances, for example, polyethylene glycol, or by polymer blending of various substances that we will discuss, and then by altering certain physical characteristics by various mechanisms. So if you kind of try to now classify membranes, and you can see that classification column has moved very much away from just being a high flux, low flux membrane to now classifying a membrane in terms of their molecular weight retention onset, their cutoffs, their approximate pore size, and their ability to clear various larger molecules, including free light chains. And I will show you some studies that would now suggest that it is not just knowing that, oh, we perform CRRT in a particular way, and then this was the amount of clearance that we got. We should probably now be describing in our studies and the scientific papers that we do, what was the membrane and what was the characteristic of the membrane, and with their various cutoffs and etc. that were used for that particular experiment. And a very good example of that is this study, which compared two polysulfone membranes, which are two asymmetrical synthetic membranes, for continuous renal replacement therapy for sepsis. And as you can see on the left side, the center table, the two membranes were from two different manufacturers. Both were polysulfone membranes. Both hemofilter membrane surface area has been defined as 1.3 meters square. So on the outside, both the filters, if you present it to me, would look okay. But if you go deeper into what were the characteristics of the membrane and the fiber diameter of the membranes, one membrane had an inner fiber diameter of 200 micrometers and the other had 225, and the thickness of the wall, which will kind of determine how easy it is for diffusion to happen. The thicker the membrane, the less is the ability to diffuse. There was slightly difference between 40 and 45 micrometer. And they did a crossover study. They started a patient first on membrane A, and after 24 hours changed to membrane B, and then they reversed this in another group of patients. And what they studied in this was the clearance of myoglobin at 1 hour mark and at 24 hours after the use of membrane, and also the clearance of creatinine. Now, it is very interesting to note that if you look at the top two figures, it is the myoglobin clearance. The myoglobin clearance with the SAG polysulfone membrane was consistently better than the performance of the AEF membrane. But if you look at the creatinine clearance of both membranes, they are the same. So what I'm trying to drive in here is that our usual kind of assessment of a membrane function would be clearance of small molecule like creatinine or urea. And if you studied both these membranes, you would come to the conclusion that they are equally effective. But if you went up and looked at the clearance of middle molecules or larger molecules, you will appreciate that there is a difference in this clearance. Now, I'm not suggesting that this difference is going to then going to transform into outcomes or not. But I just think that being aware of this fact should alert us that creatinine clearance or urea clearance that we are understanding may not just be enough. There could be other things that we may have to look into in context of these membranes. Now, how they would influence our micronutrient clearance, how they would influence the drug clearance, I think those things probably need to be studied even more. And similarly, there was another study that compared two different membranes. This was a standard high flux membrane with a molecular weight cutoff of 30 kilodaltons and a high cutoff membrane with a molecular weight cutoff of 45 kilodaltons. And in both these patients, they performed CRRT in CVVH-DF modality. Both membranes had the same surface area, but when they looked at the myoglobin clearance was understandably slightly better with a high cutoff with this high cutoff membrane as compared to a standard cutoff membrane. Again, just reiterating the point I just made with the previous slide. Now, just switching gears, the other common subset of patients that we see in our ICUs are patients who have sepsis. Now, whether they come in with sepsis or they develop sepsis during their hospital stay, it does not matter. And very simplistically put, this is what a sepsis cascade looks like. You have a microorganism that triggers off everything. Then there's release of pathogen-associated molecular patterns or damage-associated molecular patterns with their downstream effects in terms of the cells and their release of cytokines, which then eventually go on to cause systemic inflammation and activation of coagulation cascade and multi-organ failure. Now, based on our current technology, there are various targets that we can attack to try and mitigate or try and modulate this sepsis cascade to minimize their impact on multi-organ damage. And I've highlighted some microbes. We can attack endotoxins, the high mobility group box1 proteins, which are upstream mediators of the inflammatory cascade, or we can attack cytokines. And there is a rationale to try and immunomodulate in sepsis. And these are the various theories that have been put forward as to what would be the rationale of immunomodulating in sepsis to try and influence the outcome of this. And of course, the most talked about of which is the peak concentration hypothesis from Professor Ronco, and our current understanding and acceptance that of probably the cytokinetic model, wherein by removing cytokines, we kind of create a gradient between the cytokines in the blood and at the focus of infection, kind of allowing the polymorphonuclear, the neutrophils to migrate towards the site or the nidus of sepsis. And in this cartoon, I basically summarized all the various extracorporeal blood purification techniques that we have. And as you can see, these techniques can attack the cascade at various levels of cytokines at the cell level or at the microbe level. But I will just concentrate on the use of CRRT and the current use of the different CRRT membranes that have been used to try and influence the sepsis cascade. So there have been various small studies, some small randomized trials, some prospective studies and retrospective studies that have looked at the influence of high cutoff membranes or the use of high cutoff membranes in dialysis, intermittent or continuous renal replacement therapy, and see what would be their effect on cytokines, and then of course to also study the safety profile of these membranes. And what these membranes seem to consistently show in these small studies is they did have an influence on the removal of pro-inflammatory cytokines like interleukin-6, like TNF-alpha, which some in these studies seem to translate into improvement in the hemodynamics and in improvement in the requirement of vasopressor support of these patients. However, one of the things that came up from this is that when performed in the hemofiltration mode or a pure convective mode, these membranes were associated with probably unacceptable levels of albumin leakage or protein leakage that may have been in the range of 7 to 12 grams per session. And therefore, it's generally recommended to use these membranes in a diffusive modality, if at all. And there was one randomized controlled trial that looked at the use of high cutoff membranes in CVVH-DF modality versus CVVH with a standard high flux membrane. in patients with sepsis-associated AKI, and they were not able to demonstrate any improvement in mortality with the use of high cutoff membranes. In fact, in this study, the mortality with high cutoff membranes, the odds ratio of this mortality was twice that of a standard high flux membrane and CVVH. Now, the other membrane property that I have indicated and mentioned earlier, and that has been leveraged upon in CRRT, is the adsorptive capacity of these membranes. So this is a very old study that has actually shown that when they monitored the cytokine levels while using a polyacrylonitrile membrane, there was a consistent decrement in the levels of cytokines, which seemed to plateau off after 12 hours. And then if you change this membrane and replace it with a new membrane, there was again a significant drop in the cytokine levels. Again, this is kind of understandable that because we know adsorption by definition would be a saturable process. Saturable process. So it just comes to highlight that. So it just comes to highlight that based on this property of the membrane, there are certain hemofilters that have been now classified as what we call cytokine adsorbing hemofilters, because these are made of membranes that have a high adsorptive capacity. And the examples of these membranes are PMA membrane and the AN69 membrane and the polyester polymer alloy. Now, it's just in CRRT generally that we have discussed in the workshop, the clearance we always associate as what we remove in the ultrafiltrate. So if you know your volume of effluent and you know the sieving coefficient of that substance with that membrane, you can estimate the clearance. But when we are talking of adsorption, that clearance that we are measuring in the ultrafiltrate may not be representative. And if you're using just convection as a means of clearance of cytokine, you're sort of limited by what is your effluent flow rate. But when we are talking of adsorptive capacities, you are sort of limited by what is your blood flow rate and what is the total surface area of the membrane that you have for adsorption. And the use of these cytokine adsorbing hemofilters and their ability to absorb was shown in this in vitro study, wherein they used human plasma and then spiked it with large amounts of inflammatory mediators. And what they found in this study was the AN69 surface-treated membrane had the highest capacity to adsorb interleukins, cytokines, and endotoxins, and the high-mobility group box1 proteins. And there are some studies from Japan that seem to suggest, and these are just retrospective observations, that the use of these cytokine adsorptive hemofilters was associated with better outcomes in the ICU than use of standard hemofilters. So as was mentioned earlier, that the base membrane of the AN69 is a polyacrylonitrile membrane, right? And to add hydrophilicity to this membrane, they added sodium methylyl sulfonate. And the sodium methylyl sulfonate is anionic, so it has a negative charge. But this negative charge was added to sort of decrease the bradykinin activation. Now, to compensate for this negative charge, which made the membrane very bioincompatible, they were layered by a polycationic polyethylenamine, which is positively charged, and it reduced the bradykinin activation. However, this rendered the membrane surface to become very thrombogenic. So when we were priming the CRT with heparin, the heparin sort of coats itself on the polyethylenamine to reduce the thrombogenicity of this membrane. So now in the manufacturing process, during the manufacturing process, they are able to coat these membranes with substantial amounts of polyethylenamine, which is almost 3 times that of what is present on a surface-treated AN69 membrane, and 10 times the amount of heparin than what it would be if you just prime this circuit with heparin. And at these quantities, these substances, they become biologically active, and therefore they have a larger capacity to absorb both the positively charged cytokines and the negatively charged endotoxins on these layers. And this has actually again been shown in vitro studies where they studied these modified surface-treated AN69 membranes, and again with human plasma spiked with endotoxins and inflammatory mediators. And what they were able to show that in terms of the endotoxins, though these membranes absorb slightly less endotoxins than the polymyxin or the toramycin cartridges, they were sort of comparable by at about 2 hours mark. And in terms of their capacity to absorb cytokines, they were comparable to cytokine absorbing cartridges in these terms. And this was kind of replicated in humans as well, where they were subjected to CRT with these membranes, and the pro-inflammatory cytokines were measured over, and endotoxins were measured over at various periods of time. And in those patients who were who used the modified surface-treated AN69 membrane, there was a significant decline or decrement in the levels of pro-inflammatory cytokines and endotoxins, which is in the blue bars, which was not seen on the other membrane. And therefore, this use has been extended now to be used in COVID, and this is a study that has come out from Italy, which was just an observational study where they showed a decrement in these pro-inflammatory levels and improvement in their hemodynamic parameters, illness severity scores, and lesser mortality than expected for that SOFA score. So I think as we move forward, this is something that we should probably to look for and study forward. And maybe with this available technology and with various other technologies that are available, maybe our blood purification methodologies have to just move from being AKI-centric to AKI pathophysiologic-centric, where we try to influence both the outcomes of AKI and the pathophysiology of AKI, even by using just simple CRRT. Right. So with that, I would like to conclude to just say that advancements in membrane technology has allowed a wide variety of commercial hemofilter membranes, and the newer synthetic membranes have increasing capability to clear larger molecular weight substances, and the cytokine absorbing filters are being increasingly studied to determine their role in sepsis and other inflammatory states. And with that, I thank you very much for your attention.
Thank you for a beautiful overview. Any questions for Dr. Kaushik? Thank you very much again for the invitation. So my topic for today is talk about the relationship between modality and renal recovery, and whether there is a link between the two. These are my disclosures. Today we'll talk about the relationship between acute kidney injury requiring renal replacement therapy, sometimes called AKID for short, and subsequent kidney disease progression. We'll also try to understand how renal replacement therapy can affect endogenous kidney function, specifically the way we prescribe acute renal replacement therapy, and then talk about the possible link between renal replacement therapy modality and kidney recovery. So let's define kidney recovery. It's actually a complicated concept, I think. So typically, we would assess patients at day 90. Arbitrarily, we choose day 90 because that is the interface point between acute kidney disease and chronic kidney disease. And patients who have received renal replacement therapy for their AKI may have one of three kind of statuses at that time point. They can either have a full recovery, whereby they are off renal replacement therapy and their GFR has returned to baseline. They can have what I would call a partial recovery, whereby they are independent of renal replacement therapy, but their GFR is still below their pre-illness baseline. And the worst outcome, of course, if they are still dependent on renal replacement therapy at 90 days. There's a few caveats with this categorization. Number one, the baseline GFR in patients with acute kidney injury isn't always clear. Patients arrive in hospital with significant decrements in their kidney function, but we don't always know what their true baseline is, especially if they don't have blood work from the outpatient setting when they were last stable. Finally, post-illness GFR estimates may also be hard to interpret. After prolonged critical illness, patients often lose muscle mass, which means their creatinine generation goes down. It means their creatinine concentration goes down. And so often, the creatinine levels that we might measure at day 90 may be significant overestimates of their true GFR. And finally, even the so-called hard outcome of dialysis dependence at 90 days is a little bit subjective as well. To some extent, the decision about whether to keep someone on dialysis or not may be somewhat subtle and nuanced. And so this too is subject to physician practice to some extent. So the first question is, acute kidney injury, severe acute kidney injury for which renal replacement therapy is delivered, is it associated with progressive chronic kidney disease? This is a study that was published 15 years ago from the group in San Francisco. They queried the database of Kaiser Permanente of Northern California, looking at patients admitted between 1996 and 2003 who, before their AKI, had relatively decent GFRs of above 45. And they identified patients who, 343 patients who were free of renal replacement therapy at 30 days and alive after starting dialysis for AKI. And they matched these individuals in a 10-to-1 fashion to individuals who were hospitalized at around the same time and who were also alive at 30 days but never received renal replacement therapy for AKI. And their main outcome was progressive CKD, defined as developing end-stage kidney disease or having an eGFR of less than 30. And what they found was a very dramatic finding. Individuals, even those who had, remember, relatively preserved GFRs at baseline, who received renal replacement therapy for AKI had almost a 30-fold higher likelihood of progressive chronic kidney disease, either being on dialysis or having an eGFR of less than 30. This was over a follow-up of 6 years. So I think proving very convincingly that an episode of severe AKI requiring dialysis is indeed associated with progressive chronic kidney disease. In my home province of Ontario, where about 14 million patients reside, we're lucky to have universal health coverage, and that means, and the government pays for all health care. So all of the data emanating from our government databases that can kind of can be summarized in a central database, and we can understand how healthcare is delivered and what the outcomes are. So we decided to look at almost 4,000 patients who initiated renal replacement therapy for AKI between 1996 and 2006. But these were the lucky ones. They survived a hospital discharge. They even came off dialysis and remained off dialysis for at least 30 days. And then we followed these individuals to a matched cohort of people who were admitted with similarly severe illnesses but did not have severe AKI requiring dialysis. And what we found is that patients who had acute kidney injury requiring dialysis as compared to those with no acute kidney injury had a 3-fold increase in the likelihood of going back to dialysis and going back to dialysis permanently, having end-stage kidney disease. And so once again, proving, I think, that an episode of AKI requiring dialysis, even if you recover in the short term, has significant long-term kidney implications. So again, just to summarize, survivors of AKI requiring dialysis are at high risk of progressive CKD and in some cases, end-stage kidney disease. But does this matter to patients? What are actually the outcomes that matter to patients and families with acute kidney injury requiring dialysis? I think for the clinicians in the room who look after patients like this in the ICU, I think the first thing that patients, it's usually not the patients who are pretty sick and don't communicate with us, but their families want to know, will my loved one survive? That's always the most important thing. But once, the second question often is, if my loved one survives, will they be on dialysis forever? Because they may have never heard of dialysis before. The patient may not even have a history of chronic kidney disease, and suddenly his dialysis machine is being brought to the bedside. But they've heard of people, they know that dialysis is a hard life, and they want to know, if my loved one survives, will he or she remain dialysis dependent over the long term? Other important outcomes are, whether the patient will return to their previous living situation, the time they spend in the hospital, the time in the ICU. But again, if a patient survives, the most important question is, will they remain dialysis dependent or not? The ATN trial shed some light on this in a paper published last year. They looked at patients in the trial who survived to day 60, and they classified, or they categorized patients in levels of quality of life as measured by the Health Utility Index 3. They grouped patients into low impairment, moderate impairment, and high impairment. And whether a patient was dialysis dependent or not was highly linked, highly correlated with their level of impairment. Individuals who were RT dependent, 38% of them, or I should say, 38% of patients in the high impairment group were RT dependent, and this was a very important correlation. So again, to highlight the fact that dependence on renal replacement therapy after an episode of AKI is something that really matters to patients, has a strong, very potent impact on their quality of life. So the topic of recovery was actually covered in an ADKI symposium that was held in La Jolla a few years ago. I had the privilege of being part of it. Ming Chawla led the effort, and we kind of summarized at that symposium what we knew about kidney recovery after an episode of dialysis requiring AKI. That was one of the topics that we covered. And a variety of consensus statements were drafted, none of which unfortunately had a high level of evidence, but this is kind of what was summarized. Renal recovery after an episode of AKI requiring dialysis is defined as sustained at least 14 days of independence from dialysis. Statement B said that current tools and diagnostics are insufficient to accurately assess kidney function in patients receiving acute dialysis. We don't have a great tool to measure kidney function or endogenous kidney function while patients are on RRT. And in fact, we don't even have, our tools are even limited when they come off RRT. Statement C said that limited data exists on how to use clinical factors and diagnostic tests to reliably predict non-recovery among patients with dialysis requiring RRT. Can we tell a loved one at the bedside, I believe your loved one, if they survive, is going to recover? We don't have the best tools for this just yet. We also don't have great data regarding how to deliver renal replacement therapy to improve kidney recovery. And finally, there is insufficient data to recommend specific processes of care or techniques to improve renal and patient recovery in patients with dialysis-dependent acute kidney disease. So it's a field that very much needs better answers, and hopefully I'll try to answer some of these with data that's come out over the last few years. The first question is, can we predict whether a patient will have recovery or not once they start dialysis in the context of AKI? This is work also done by the group at Kaiser Permanente of Northern California. Chi Su's group in San Francisco led this. And they looked at over 2,000 adults in their healthcare system who received dialysis for AKI between 2009 and 2015. This is both in ICU and in non-ICU settings. They excluded individuals who were perceived to have a very high risk of death and a baseline GFR of less than 15. And they defined recovery as being off renal replacement therapy by 90 days and alive for 4 weeks after the last dialysis session. And using this definition, 41% experienced what they called recovery. Now, what were the predictors of non-recovery? Briefly, the key predictors were, or I should say the predictors of non-recovery were the presence of liver disease, a low baseline eGFR, and severe anemia. So all very easy to identify risk factors for non-recovery, but when you put it into a global model, the C statistic was only 0.64, so not a lot, very limited discrimination. So unfortunately, we have a lot more to learn about predictors of recovery. And this is perhaps where machine learning might come into play. What about how renal replacement therapy can affect endogenous kidney function? In other words, how we deliver renal replacement therapy, does that matter? So this was a really kind of almost iconic diagram by Ming Chawla in a paper that he published in the New England Journal a decade ago. And he talked about the link between AKI and CKD. And it was a seminal paper because at the time, we always appreciated that chronic kidney disease was a very potent risk factor for developing AKI, say after cardiac surgery in the setting of sepsis. That's old news. But what Ming highlighted in this paper was, at the time, much more recent data that showed that an episode of AKI also impacts on subsequent chronic kidney disease. And Ming highlighted common risk factors to AKI and CKD, disease modifiers that were common, as well as outcomes that were common. But what he didn't mention, I think, is a really important point. And the question is, does the way in which we manage an episode of AKI impact on long-term kidney outcomes? Can we change kidney outcomes by the way we care for patients with AKI? So what evidence do we have for the mechanistic link between renal replacement therapy and CKD in AKI survivors? So this is going back to the days of the Vietnam War. We had soldiers who developed AKI in the context of severe trauma, usually, and they had oligoanuric AKI, and they received dialysis. And then patients weren't recovering from their AKI, and biopsies were done a few weeks into the patients being on dialysis. And the shocking discovery was the fact that the patients had new areas of ischemia 2 weeks after their initial injury. So what was this new injury that caused these new acute hits to the kidney while the patient was on dialysis? And the thinking was it was at the hemodynamic stability of the dialysis process itself that could have contributed to it. The theory behind this is that patients with acute kidney injury have impaired renal autoregulation. And so when they're faced with a hemodynamic stress and intradialytic hypotension, as happens often when patients are receiving conventional dialysis, they have decreased renal perfusion pressure, impaired renal blood flow, and tubular ischemia. So normally the protective effects of autoregulation that exist in our healthy kidneys do not exist when patients have AKI. The concept was validated in animal models, but has limited human data, unfortunately. But there is, from the maintenance dialysis world, which is the other world in which I inhabit when I'm not in the ICU, there's a lot of very interesting data linking intradialytic hypotension and organ ischemia. And the person we have to credit most for this is Dr. Chris McIntyre. He's a British nephrologist who's now relocated to Canada a few years ago, and he's done seminal work showing the effects of maintenance conventional dialysis sessions on the heart, the concept of myocardial stunning, the fact that patients effectively have little MIs when they're on dialysis. These are chronic, ostensibly stable dialysis patients. But the other organs that are affected are not just the heart, the brain is affected, and this might explain the cognitive decline that occurs in patients who have end-stage kidney disease. The liver is affected, the gut is affected with higher risk of gut ischemia. And of course, the organ that we often forget about in maintenance dialysis is our own kidneys. Those kidneys as well suffer ischemic hits and may explain why patients receiving chronic hemodialysis end up losing their residual kidney function and become oligoanuric several months after they commence conventional dialysis. So the question is, does this concept that is so well defined in the ESKD population, does it apply to the acute dialysis population, patients with AKI? And in fact, Chris McIntyre and Louis Forney and other colleagues looked at this, albeit on a smaller scale, in patients who were receiving conventional dialysis for AKI. 11 patients who were receiving 4 hours of IHD for AKI. They were hemodynamically stable. They were not on pressors. Not a lot of fluid was even being taken off, 5 mils per kilo per hour on average. And the patients didn't experience any intradialytic hypotension. But when they put the echo probe on the patients, they found that all patients had at least 2 segments of their myocardium that had a wall motion abnormality. In other words, this concept of myocardial stunning also exists in patients receiving dialysis for AKI. So I would extend that question to ask, does kidney stunning also occur during acute RRT? So I want to talk about this concept of kidney stunning and appreciate the link or the potential link that might exist between renal replacement therapy modality and renal recovery. So the debate about modality is older than almost me, and certainly longer than I've been in practice as a nephrologist. So we all know, I think, that RCTs, the few RCTs that have been done comparing CRT and IHD, show no difference at all in terms of all-cause mortality. But does modality impact on kidney recovery, which is still such a vitally important outcome to patients requiring acute dialysis? So we know that CRT offers better hemodynamic tolerability than IHD. This is thanks to a lower ultrafiltration rate, the ability to fine-tune ultrafiltration rate in response to the dynamic circumstances of the patient, and finally also CRT confers a slower solute removal rate. And this classic trial by Joshua Augustine from the Cleveland Clinic, now 2 decades ago, highlighted this. This is a trial of 80 patients who were randomized to either receiving CVVHD or conventional intermittent hemodialysis. And they showed that intradialytically, blood pressure was more likely to decrease among recipients of IHD as compared to those who were receiving CRT, where blood pressure remained stable. But it wasn't a huge difference in MAP. But the important message here, remember when patients are in the ICU, there are iatrogenic factors too. And sometimes drops in blood pressure when patients are in the ICU are mitigated or blunted by escalations in the pressor dose that the nurses do as part of a protocol. And so importantly, patients who are receiving IHD also require greater escalation in their pressors. Blood pressure drop as well was associated with non-recovery of kidney function. So these little blips of intradialytic hypotension, which we may not bat an eyelash at, actually do matter, and they may impact on the likelihood of the patient recovering kidney function. So let's look at the literature that has compared CRT and IHD and what we can learn from that literature in terms of kidney recovery. This is Antoine Schneider's work from about a decade ago, and he looked at all the studies that were available at the time comparing CRT and IHD with a specific focus on renal recovery. And he found that patients, at least in the observational studies that were published until that time, there was a twofold higher likelihood of patients recovering kidney function if they received CRT as compared to IHD. When he shifted over to looking at the clinical trials, the RCTs that were done, he was unable to show a difference between those two modalities. But I think the important reason for that is right over here. He only had about just under 500 patients to study, and the incidence of kidney recovery was relatively low. And part of the reason he had so few patients to study is that we know that mortality is so high in patients who receive acute dialysis in the ICU. And so the number of patients to whom the question of renal recovery is even relevant is relatively small, and showing a difference, therefore, becomes difficult in clinical trials. So again, to highlight, since mortality in these trials is very high, renal replacement therapy dependence is a relatively infrequent outcome. And completed trials, including our own START-AKI trial, lack statistical power to detect a difference in renal replacement therapy dependence, at least when you look at modality. Now, let's look at the different trials that have been done in the area of critical care nephrology, the hemodiaph trial, the dose trials of the ATN, the renal trials, the ELAINE, the AKIKI, the START-AKI trials, and most recently the RICH trial looking at heparin versus citrate. Mortality in all these trials is quite high, but renal replacement therapy dependence is actually very low. So if you wanted to design a trial, let's say comparing CRT and IHD, but your interest was only looking at renal replacement therapy dependence, you would have to recruit well over 5,000 participants, which makes the trial quite infeasible, in my opinion. So in the absence of clinical trials in this area, what can we learn from observational studies that have been conducted? So about a decade ago, we again queried our Ontario databases, looking at individuals who had received acute dialysis in our province between 1996 and 2010. And we identified 2,004 patients who initiated dialysis with CRT and survived to 90 days, because that's the group we were actually interested in, because we were interested in renal recovery. And we matched them to individuals who commenced dialysis with IHD, who were also alive at 90 days. And what we found was at 90 days, individuals who received CRT were about 25% less likely to still be dialysis dependent. And when we followed the cohort out for up to 10 to 12 years, this relationship persisted. In other words, the initiation of dialysis with CRT conferred a 25% reduction in the risk of end-stage kidney disease, both at 90 days and beyond. And this association was particularly potent in patients who had a background of CKD. These are the patients we worry about most, who don't have a lot of renal reserve, and even if they receive dialysis for AKI, we don't want that to be their last hit in terms of going on to end-stage kidney disease. These are the patients who seem to benefit most from receiving CRT. In the START-AKI trial, we also interrogated this question and wanted to know what we can learn about modality. Now, START-AKI was not a modality trial per se. Just to refresh your memory, START-AKI was a randomized trial of earlier versus later renal replacement therapy initiation in critically ill patients with severe AKI, conducted in 168 centers around the world at 15 countries. In the accelerated arm, we administered renal replacement therapy within 12 hours of the patient meeting eligibility criteria. In the standard arm, we discouraged the initiation of RRT unless one of the so-called classic urgent indications for RRT arose. And our primary outcome was all-cause mortality at 90 days, but we also collected data on renal recovery and defined in different ways. So as many of you probably know, there was no difference in mortality between the accelerated arm or the standard arm, but we did find that RRT dependence among survivors was almost twofold most likely among patients randomized to the accelerated arm. But again, the question of this talk and what we did in this sub-study was really about modality. And some of you may ask, well, what did you do about modality? How did you choose what dialysis modality you would use in START-AKI? So it was a pragmatic trial, and we told clinicians that they should use whatever modality was felt to be in the patient's best interest, and based on also what was available at that center. But we did suggest that they use CRT or SLED in sites where that were using SLED in patients who were hemodynamically unstable, and to reserve the use of IHD for patients who were felt to be more hemodynamically stable. And of course, transitions between modalities could occur depending on the patient's hemodynamic status. In the trial, 70% of patients initiated dialysis with CRT, and about a quarter with IHD, and a very small minority with SLED. So again, this was not the modality was not part of the randomized treatment allocation. So we said, we did the following. We took the nearly 3,000 patients in the trial who were in the modified intent to treat analysis and focused on the 2,321 patients who had received renal replacement therapy. We excluded those who received SLED and about whom there were questions what modality they actually started with. And this left us with 1,590 patients who initiated renal replacement therapy with CRT and 606 patients who initiated therapy with IHD. And you can say, well, this might be a very messy comparison. And indeed it was, because as you would imagine, individuals who started with CRT were different than those who started IHD. They tended to be younger. They tended to have higher baseline GFRs. They were sicker based on higher SOFA scores and SAP scores. They had a higher likelihood of being on mechanical ventilation and receiving vasoactive medication. Same goes for their fluid balance, which was different between the two groups. So again, it was a difficult comparison to make because this was not a randomized comparison. So we did the following to try to level the playing field, if you will, between the two treatment strategies of CRT versus IHD. We created a propensity score, which is really a logistic regression-derived score that took all the covariates that were available to us and said, what is the likelihood of this patient receiving CRT? Even if he or she didn't receive CRT, it didn't really matter. We want to know, what is the likelihood of this patient getting CRT? And then what we did was something called inverse probability of treatment weighting. We took patients who were receiving CRT and weighted them by 1 minus their propensity score. This ensured that patients who were the sickest CRT patients contributed least to the subsequent analysis. And then we took patients who received IHD and weighted them by the likelihood of receiving CRT. This ensured that the sickest of the IHD patients contributed the most to the analysis. So the idea is to remove the extremes, the healthiest IHD patients and the sickest CRT patients, and create what we call the pseudo population that aims to compare the two treatment groups on a more level playing field. And the result of this weighting process is excellent balance in baseline characteristics. You can see now that the differences between CRT and IHD that were seen in the crude data almost disappeared when you do what's called overlap weighting. And so the typical patient that we compared was a man in their mid-60s, SOFA score, mechanical ventilation, vasoactive medication. All those important confounders were now perfectly balanced. And so we can compare these two weighted pseudo populations of CRT and IHD recipients, and we found the following. Our primary outcome of death or RT dependence at day 90 was statistically significantly lower among patients who initiated CRT. But this was mostly driven by the likelihood of patients being RT dependent. So there's a 40% reduction in RT dependence at day 90 among patients who initiated CRT compared to IHD. No difference in all-cause mortality at 90 days. By the same token, patients who initiated dialysis with CRT had more ICU-free days and more hospital-free days as well. So to conclude, I think we all agree that sustained independence from renal replacement therapy is a vital outcome for patients initiating renal replacement therapy for AKI. The mitigation of hemodynamic instability may have important effects on kidney outcomes after an episode of AKI, and it's something we should always strive for when managing our patients. And finally, I think it's fair to say that although there are no RCTs to show this, there are still mounting data to suggest that the deliberate use of CRT can heighten the likelihood of renal recovery and dialysis independence following an episode of AKI. Thank you very much for your attention. I want to acknowledge all our funders And I think we may have time for a question or two. Okay. Anyways, thank you all for attending this session and have a wonderful day.